Welcome to the deep dive. Whether you're a medical student, a junior doctor, a public health trainee, or, a practicing clinician, you are absolutely in the right place today.
Glad to be here.
So today we're doing a structured conceptual deep dive into public health frameworks. The goal here is really to strengthen your clinical and policy reasoning. And to do this, I want you to imagine something.
A metaphor, I'm guessing.
Exactly. Imagine that building a society's health is it's like constructing a massive, intricate skyscraper.
Okay, I like that.
Right. So first, before you even pour a single ounce of concrete, you need an airtight legal blueprint and a structural foundation. In our metaphor, this foundation is the right to health. It's what transforms health from this optional charitable gift into a binding structural obligation.
A literal legal requirement.
Yes. And second, once the building is actually up, you need a high-tech security and early warning radar system to protect the people living inside. That radar is population screening. It actively scans for threats. But as we're going to see today, it requires incredibly precise calibration so those alarms don't just cause widespread panic.
That is a really great way to visualize it. Our mission for this deep dive is to essentially map out this entire architecture. We're drawing directly from the Oxford textbook of global public health.
Right.
So we'll start by examining the legal architecture of human rights in health, which is from chapter 3.3, and then we'll apply systems thinking to the complex and, honestly, often counterintuitive world of population screening.
Which is chapter 11.4.
Exactly. And by the end of this, you'll see exactly how the foundational law and that early warning radar depend on one another.
I've always been really fascinated by this shift in how we view public health. It used to be framed as just this nice-to-have charity initiative or, good moral rhetoric.
Yeah, polite suggestion.
Right. But now it's literally embedded in international law. I mean, we're talking about the World Health Organization Constitution of 1946 and the International Covenant on Economic, Social, and Cultural Rights.
It's a massive paradigm shift. Framing health as a human right creates a formal legal relationship. It creates what we call duty bearers, which are the states or the governments, and rights holders, which are the individuals.
So it moves health from a commodity to an actual obligation.
It does, but we really need to clarify the scope of that obligation carefully, because the right to health does not mean the right to be healthy.
Right, because genetics happen, biology happens. You can't legislate perfect health.
Exactly. International law defines it as the right to the highest attainable standard of physical and mental health.
Okay, but what does highest attainable standard actually mean in practice? Because that sounds incredibly vague.
It does sound broad.
Yeah, and if I'm a public health professional, I know my work extends way beyond the walls of a medical clinic. Does this legal standard account for that?
It absolutely does. It explicitly includes the underlying determinants of health. You just can't achieve the highest attainable standard without access to safe water, proper sanitation, adequate housing.
Healthy occupational environments.
Yes, the law recognizes that health is produced in the community, not just repaired in the hospital.
Okay, so let's say I'm a health minister. How do I actually measure if my clinics and my public health programs are up to standard? I need some sort of operational metric, right?
You do. And the framework you're looking for there is AAAQ, AAAQ. It's the standard for evaluating health services, goods, and facilities.
AAAQ. Okay, let's break that down. What is the first A?
The first A is availability. Services, goods, and programs simply must exist in sufficient quantity within the country.
Makes sense. You can't guarantee a right to health if the physical hospitals or the supply chains for essential medicines just don't exist.
Right. It's the bare minimum.
Yeah.
So if the clinic is built and stocked, we've hit availability.
Okay, what's the second A?
The second A is accessibility, which actually has 4 distinct dimensions to it.
Oh, wow. Okay.
Yeah. First, non-discrimination. Services have to be accessible to everyone, especially vulnerable groups. Second is physical reach, meaning safe geographic access.
Right, because it doesn't matter if the clinic is built if it's a 3-day walk across dangerous terrain to get there.
Exactly. Third is economic affordability, and fourth is accessible information, so people can actually make informed decisions about their care.
That is a heavy lift for a government. Okay, so we have availability and accessibility. What's the third A?
Acceptability. Services must be culturally appropriate and respectful of medical ethics.
So a clinic might be physically close and affordable, but if the staff treats certain demographics with disrespect or ignores cultural contexts surrounding care,
then it fails the acceptability test, and patients simply won't use it.
right. And the final letter, the Q.
Quality. The care must be scientifically and medically appropriate, Having unexpired drugs, safe drinking water at the facility, adequately trained medical professionals, all of that falls under quality.
So, AAAQ. Availability, accessibility, acceptability, and quality. If that's the metric, what are the actual legal mechanics for the government? Like, if they are the duty bearers, what are they legally required to do?
The state has tripartite legal obligations: respect, protect, and fulfill.
Okay, let's take those one by one. Respect.
The obligation to respect means the state must do no harm. They have to refrain from interfering directly or indirectly with the right to health.
So a government cannot engage in forced sterilizations or run state-sponsored projects that knowingly pollute local water supplies.
Right. They essentially have to stay out of the way of health. Then there is the obligation to protect. This means the state must stop third parties from doing harm.
Like regulating private corporations.
Exactly. Making sure they don't dump toxic waste or preventing abuses in private healthcare settings.
Okay, and the third obligation.
The obligation to fulfill. This requires the state to adopt actual legislative, administrative, and budgetary measures to realize the right. They have to proactively fund a national health plan or an immunization program.
Okay, but come on, let's be realistic here. How can a low-income nation possibly be held to the same legal standard as a wealthy European country? That seems like an impossible legal mandate to fulfill.
That is a very common pushback. And the legal framework actually accounts for it through a concept called progressive realization.
Progressive realization.
Yes, the law acknowledges resource constraints. What is legally expected of a wealthy nation differs from a developing one. However, and this is key, the state must show measurable, continuous improvement over time, using indicators and benchmarks.
Ah, so they can't just throw their hands up and do nothing because they are poor.
Precisely. They have to prove they're moving in the right direction with whatever resources they have. Furthermore, there are obligations of immediate effect.
Which means?
Principles like non-discrimination apply instantly, regardless of how tight the national budget might be. You don't need a massive GDP to stop discriminating against a minority group in your existing clinics.
That is a crucial distinction. Now we actually see this playing out in the real world. The text highlights some fascinating precedents where courts genuinely held governments accountable.
Yes, the judicial enforcement side of this is powerful.
Right. There's a case in South Africa, Minister of Health v. Treatment Action Campaign. The Constitutional Court literally mandated that the government devise and implement a comprehensive program to provide medications that prevent mother-to-child HIV transmission.
They enforce the obligation to fulfill.
Exactly. And there's another example from Peru, KLV Peru, where the UN Human Rights Committee held the government accountable for denying a young woman a legally permitted therapeutic abortion when her life was at risk.
Those cases perfectly illustrate the judicial enforcement of the right to health. The blueprint is binding. But, if we go back to our metaphor, a strong blueprint and a solid foundation alone do not keep the inhabitants of our skyscraper safe from incoming active threats.
That is a perfect pivot. If the law says the government has to protect us, then population screening feels like the ultimate tool to do that. You just install a radar on the roof, scan everyone, find the disease early, and save the day, right?
Well, we have to be really careful with our terms here, especially for the clinicians listening. What you do in a clinic isn't necessarily population screening.
Walk me through the difference.
Clinicians commonly use the term screening when they systematically check their existing patients. For example, doing an annual retinal exam on a diabetic patient to check for complications.
Or running a blood panel on someone who comes into the clinic asking for a general checkup.
Right. That is technically opportunistic testing or case finding.
Ah, okay. So what makes population screening different?
Population screening is a systematic public health service that actively invites healthy, asymptomatic people who do not necessarily perceive themselves to be at risk.
You are reaching out to the general public, not just the people sitting in your waiting room. And that brings up a massive ethical shift, doesn't it? Because if a patient comes to me with a problem, they're asking for help. But if I, as the public health provider, am actively reaching out and inviting healthy people to undergo a medical intervention, my ethical burden is immense.
It really is. The implicit promise you are making is that the benefit of this screening will definitively outweigh the harm. And make no mistake, screening causes harm.
Right, because we tend to just think of the benefits of catching something early, but the harms are real. We're talking about false reassurance for those whose disease is missed.
Yes.
We're talking about false alarms that cause severe psychological anxiety. There's the overtreatment of questionable abnormalities that might never have caused a problem, and there's the physical hazard of the test itself, like radiation exposure from mass imaging.
To navigate these harms, public health uses the Wilson and Youngner criteria. It's the gold standard framework, which has been updated over time by bodies like the UK National Screening Committee. This framework emphasizes that screening is not just a test, it is an entire pathway.
What are the main pillars of that criteria?
First, the condition has to be an important health problem with a known natural history. You have to understand how the disease progresses from latent to clinical stages.
Second.
The test itself must be simple, safe, and precise. And third, crucially, there must be an effective treatment available, and intervening early must definitively yield better outcomes than waiting for symptoms to appear.
Because there's no point in screening for a disease if early detection doesn't change the patient's ultimate prognosis.
Exactly.
Let's talk about the accuracy of this radar, because this is where the epidemiology gets really fascinating. If I'm a clinician in an emergency department and a sick patient comes in, I want to test with incredibly high sensitivity. I do not want to miss the disease.
Naturally.
But if we are talking about population screening, is sensitivity still the most important metric?
Surprisingly, no. This is a conceptual trap for many clinicians. In population screening, the disease prevalence in the general public is usually very low, often less than 1%. When you are testing tens of thousands of completely healthy people, specificity, which is correctly identifying true negatives, becomes incredibly crucial.
Okay, let's work through the math on this, because the textbook gives a brilliant example using beta thalassemia. Let's say we have a test. We use a mean cell hemoglobin, or MCH, cutoff of 27 picograms. That gives us 100% sensitivity.
Right.
We miss absolutely no one who has the disease. Now, if you deploy that test in a high prevalence setting, like a specialist hospital, the positive predictive value, or PPV, is around 77%.
Which means if the test rings the alarm and says positive, there is a 77% chance the person actually has the condition. That's a highly functional radar.
Makes total sense. But what happens when we take that exact same test with the exact same 100% sensitivity and we deploy it into a low prevalence general population?
The positive predictive value plummets to 1.3%.
Wait, let me get this straight. We have a test that catches 100% of the disease. But
Let's start with length time bias. This occurs because screening inherently catches slow-growing, less aggressive tumors.
why is that?
Think about it. A fast-growing, aggressive tumor often appears, causes symptoms, and forces the patient to the doctor in the interval between their scheduled population screenings.
Oh, I see.
Because screening disproportionately catches the slower, more benign cases that hang around longer in the asymptomatic phase, the survival statistics of screen-detected cases look artificially better than they really are.
Because you're effectively selecting for the better tumors just by the nature of the schedule.
Okay.
And what about lead time bias?
Lead time bias happens when detecting the disease earlier doesn't actually extend the patient's life. It just moves the diagnosis date backward.
Can you give an example?
Let's say without screening, a patient would notice symptoms at age 65 and die at age 70. With screening, we catch the disease at age 60, but our treatment still can't change the outcome, and the patient still dies at age 70.
Wow. So the survival time appears longer on paper, 10 years instead of 5 years. But the actual time of death wasn't delayed at all.
Right.
They just lived a longer period of time with the knowledge and the anxiety of having the disease.
Exactly. It's an illusion of improved survival.
That is deeply sobering, and it really forces us to look at the economics of screening. Every dollar spent on screening tens of thousands of healthy people is a dollar not spent treating sick people in the hospital. These are massive opportunity costs.
And pre-assessments of screening programs almost always underestimate the hidden costs. It's never just the cost of this swab or the scan.
What else goes into it?
You have to pay for the massive IT systems required for call and recall, the rigorous quality assurance boards, the pathology labs.
Follow-up biopsies for all those false positives we talked about?
Yes, and the broader economic impact of patient anxiety and work absences.
If the math is this tricky, and the biases make it look better than it is, and the opportunity costs are this high, why is it so incredibly hard to shut down a bad screening program once it starts?
It comes down to human nature and political pressure. We call it the popularity paradox. It states that the greater the harm a screening program causes through overdiagnosis and overtreatment, the more popular it becomes.
That sounds completely backwards. How does causing harm make a program popular?
Because the individuals who are overdiagnosed and overtreated fiercely believed that the screening saved their lives. Even if the abnormality they had was benign and would never have harmed them, they went through the surgery or the treatment and they survived.
So they form powerful vocal advocacy groups.
Exactly. They become the face of the program, making it politically toxic for any health minister to shut it down.
The text gives a really stark example of this with the Japanese child neuroblastoma screening program. It was a massive initiative that started in 1985, but eventually independent evidence definitively proved that the screening did not reduce mortality at all.
And it was actively causing harm by subjecting infants to unnecessary surgeries and chemotherapies.
But here's the key. It was only successfully stopped in 2004 because, thankfully, in this specific instance, there were no powerful advocacy groups to politically block the cancellation. The government was able to act purely on the independent evidence without facing a massive public backlash driven by the popularity paradox.
So if we synthesize everything we've talked about today, and we bring our high-tech radar back down to the legal foundation of our skyscraper, population screening must operate within the right to health framework.
Right. Screening is a public health service, which means it is subject to the AAAQ framework and our human rights obligations. It has to be equitable.
Precisely. It cannot just be an opportunistic perk that only serves wealthy, health-conscious groups who know how to navigate the IT systems. If a state implements a targeted screening program, say, only funding screening for women's cancers equity demands, they actively evaluate the health needs of men and minority groups to ensure non-discrimination and fair resource allocation across the entire population.
The right to health requires transparency, active participation from the community, and strict monitoring. Governments are legally accountable for ensuring that the benefits of screening truly justify the massive diversion of resources and that those resources are distributed fairly.
It's a delicate balance.
Which brings us to a final provocative thought for you to mull over as you integrate these frameworks into your own practice. We've established that the right to health demands equitable resource allocation, and we know population screening is incredibly costly and complex. Today, commercialized, personalized genomic screening is becoming widely available directly to consumers. Anyone can mail away their DNA for $50.
Oh, the direct-to-consumer testing.
Exactly. So how will public health systems handle the tension? When thousands of individuals demand endless, publicly funded follow-up tests for every minor genetic variant flagged by a private company, how will governments fulfill their legal obligation to the overall population's health without bankrupting the system through the massive opportunity costs of chasing down commercial false alarms?
It is a profound challenge for the next generation of health leaders.
All right, before we let you go, the expert here is going to put us both in the hot seat. Let's see if we actually locked in these frameworks. Hit me with a rapid-fire quiz. I'll read out the prompts for you listening at home. Take a brief pause so you can think, and the expert will give us the answer.
Let's do it. 6 rapid-fire single best answer prompts based on today's chapters.
All right, prompt 1. Under the TERE-AQ framework, ensuring a clinic provides medically sound, unexpired drugs falls under which specific category? Take a second.
The answer is quality. You can revisit Chapter 3.3 for consolidation.
Prompt 2. What is the primary epidemiological difference between population screening and opportunistic case finding? Think about who we are targeting.
Population screening systematically targets healthy, asymptomatic individuals, whereas case finding is non-systematically offered to existing patients. Revisit Chapter 11.4.
Excellent. Prompt 3. In a public health screening program for a very low prevalence disease, why is high specificity absolutely critical?
To prevent false positives from outnumbering true positives, which would fatally lower the positive predictive value, or PPV. Revisit Chapter 11.4.
Got it. Prompt 4. Which specific state obligation requires a government to pass legislation and allocate budget to ensure health rights are met?
That is the obligation to fulfill. Revisit Chapter 3.3.
Prompt 5. What type of bias occurs when a screening program appears to improve survival rates simply because it detects the disease earlier in its natural course without actually delaying the time of death?
That is lead time bias. Revisit Chapter 11.4.
And finally, prompt 6. The legal principle that a state must continuously improve its citizens' health rights over time while acknowledging current resource constraints is known as what?
Progressive realization. Revisit Chapter 3.3.
Well, I hope you at home aced that. Thank you for joining us on this deep dive. We highly encourage you to read chapters 3.3 and 11.4 in the Oxford Textbook of Global Public Health alongside this discussion to fully cement these frameworks. Keep questioning, keep learning, and we'll catch you next time. Here are the details of this episode.
The right to the highest attainable standard of health. Byline. Health not as charity, but as obligation. The legal architecture of dignity.